Aspirin has been used for coronary artery disease and has been the mainstay of therapy for preventing subsequent heart attacks and strokes for secondary prevention. There have been a few systematic reviews and meta-analyses done addressing this issue of whether aspirin should continue to be the drug of choice for secondary prevention, without any clear conclusions. Most recently, and just published a few days ago actually in JACC, was the PANTHER analysis that attempted to address this question, and it concluded that P2Y12 inhibitors might be preferred over aspirin monotherapy for long-term secondary prevention in patients with established coronary artery disease. And I'm excited to say that we're not quite there yet. We're getting close to having enough data, but we just need better quality data in my humble opinion. In this video, I'll dive into the included trials and give you my take on whether the preferred antiplatelet agent for secondary prevention crown should be bestowed upon the B2Y12 inhibitors over aspirin in 2023. I'll also go over some other data that was not included in the PANTHER meta-analysis to give us some idea of what the whole body of literature is saying regarding this question. I'm Herb, the heart pharmacist, and on this channel, I review the most up-to-date and evidence-based information on heart medications and supplements to help people choose wisely and help them lead longer and healthier lives. Let's dive right in. So the PANTHER meta-analysis published in JACC on July 11, 2023 included 7 randomized trials that included over 24,000 participants that compared P2Y12 inhibitor monotherapy compared to aspirin monotherapy for those with established coronary artery disease. They looked at both a composite endpoint of cardiovascular death, myocardial infarction, and stroke. Secondary outcomes included major bleeding and net adverse clinical events. And I must say, I'm still a little disappointed with the data that the authors of this meta-analysis had available to them. The ASCET trial was a relatively small, single-center, randomized, open-label study published in 2012 that compared aspirin versus clopidogrel for stable coronary artery disease documented by coronary angiography, looking at a primary composite endpoint of death, myocardial infarction, ischemic stroke, and unstable angina with a 2-year follow-up. A significant number of patients in the clopidogrel arm actually discontinued therapy, and more people had diarrhea and rashes and various other effects, including dizziness, general discomfort, and other side effects that were not included in the publication. Overall, there was no significant difference in the composite endpoint between aspirin and clopidogrel. In the older cadet trial published in 2004, the year that I actually graduated from high school, was an even smaller trial, but was a randomized, double-blind, multi-center trial that included only 184 patients who were actually quite acute given that they were enrolled 3 to 7 days after an MI. They also had the shortest follow-up of all the trials at 6 months, as it was more designed as a biomarker study looking at CRP, fibrinogen, D-dimer, and various other surrogate markers. So very different compared to all the other trials included in the meta-analysis. First of all, we don't actually use aspirin or clopidogrel monotherapy usually immediately post-MI, regardless of whether they get PCI or not, unless they're awaiting bypass surgery or have significant bleeding risks that preclude the ability to use a second antiplatelet agent. When you look at the baseline characteristics of the two arms, there were numerically twice as many people in the clopidogrel arm that had heart failure compared to those in the aspirin arm. That suggests to me that there probably weren't enough people randomized into this trial to balance out that characteristic. Initially, I thought that I probably would not have included this trial in the meta-analysis, given that these patients were clearly more acute than a stable CAD type of patient. Now, the famous randomized control trial of Capri was published in Lancet in 1996 that included patients with prior MI within 35 days of randomization or stroke within 6 months, had the lion's share of the patients included in this meta-analysis. And it looked at comparing clopidogrel versus aspirin in the reduction of the composite outcome of ischemic stroke, myocardial infarction, and vascular death. This is the trial that I often refer to for those who are not able to tolerate aspirin for whatever reason. They found that clopidogrel had an annual 5.32% risk reduction of the primary endpoint compared to 5.83% with aspirin. And they found that difference to be statistically significant with a small relative risk reduction of only 8.7% in favor of clopidogrel, which, if you do some simple math, is only roughly a 0.5% absolute risk reduction. The problem that I have with including the Capri trial in the meta-analysis was that it was done in an era where a lot of people were not actually on great medical therapy, including high-potency statins. I suspect that the difference between clopidogrel and aspirin may even be less significant with people being on better statins these days. More people had diarrhea and rashes with clopidogrel in the study as well. They also had the longest follow-up out of all the trials, unless you include the extended host exam analysis that stretched out just under 6 years. One of the differences that they had was that they used a higher dose of aspirin at 325 milligrams as opposed to anywhere between 81 to 160 milligrams most of all the other trials used. The GLASSY trial was a pre-specified ancillary study of the Global Leaders trial, and they randomized patients to either 1 month of DAPT followed by 23 months of ticagrelor monotherapy, or the standard DAPT for 12 months followed by 12 months of aspirin following PCI with drug-eluting stents. What they found was that ticagrelor monotherapy after 1 month of DAPT was non-inferior to what we would typically do, which is put everybody on DAPT for a full year, then keep them on ASA indefinitely. The primary composite outcome of all-cause death, MI, stroke, or urgent target vessel revascularization was lower in the DAPT for 1 month followed by ticagrelor for 23 months regimen, which was largely driven by urgent target vessel revascularization, which is a very subjective endpoint if you think about it. But anyway, this trial demonstrated non-inferiority of this regimen, this idea of cutting the DAPT therapy duration much shorter. The problem with including this trial was that it wasn't really comparing ticagrelor monotherapy at the same time as aspirin monotherapy, as the time of when they start ticagrelor monotherapy is month 2 from the index event versus month 13 for aspirin after they've received DAPT for a year. Interestingly, too, is that when you look at the bleeding outcomes overall, there were more bleeds in the experimental arm with the shorter duration DAPT but longer duration of ticagrelor monotherapy, which is consistent with my suspicion that ticagrelor may carry a larger bleeding risk than is advertised. They do, however, conclude that ticagrelor monotherapy is associated with lower rates of stent thrombosis and myocardial infarction during the second year compared to conventional therapy. The TICAB study was a relatively more recent trial in 2019 that looked at antiplatelet therapy strategies in patients undergoing CABG surgery. The primary outcome that they looked at was a combination of CV death, heart attacks, repeat revascularization, and stroke occurring within 12 months after the surgery. Now, there's some controversy already pertaining to whether patients immediately post-CABG should be receiving dual antiplatelet therapy, and I may dive into that subject in another video. But this study wanted to see if there was any difference if patients were to receive ticagrelor 90 milligrams twice a day versus aspirin 100 milligrams a day, as there's a thought that ticagrelor could perhaps preserve graft patency better than aspirin, or that ticagrelor monotherapy may have some pleiotropic effect that aspirin may not possess. I may review ticagrelor's possible pleiotropic effects in a future video, so let me know in the comments below if that's something that would interest you or whether there's some other heart medication that you'd like to learn a little bit more about. So going back to the TICAP study, it was actually stopped early after the Drug Safety Monitoring Board went on an unblinded analysis and revealed that the ticagrelor arm had higher event rates, which I thought was interestingly and suspiciously embedded in the results section that for those glazing through the article can easily miss. I know I have several times. They concluded that there was no significant difference in the primary outcome between the groups, By stopping this study early, they've essentially halted the collection of possible further harm caused by ticagrelor. Under the limitations section of the paper, the authors state that they were advised by the Drug Safety Monitoring Board to stop the trial given that there was not enough events and would require increased enrollment, but did not mention the reason for why AstraZeneca withdrew funding, which was probably because they knew ticagrelor was being outperformed by aspirin. The host exam study was the most recent trial done in Korea, which was a randomized open-label multi-center trial to study the difference between aspirin and clopidogrel after PCI for patients who have not experienced an event prior to randomization between 6 to 18 months. It drives me bonkers why this trial was not double-blinded. Had this trial been double-blinded, as well as the extended follow-up, I would be pretty convinced that clopidogrel would be the way to go. When you look at the endpoints for host exam extended, you will notice that there were statistically significantly more strokes, both ischemic and hemorrhagic, in the aspirin arm, as well as readmissions for ACS, which were the driving factors for the primary composite endpoint. There was more major bleeding and more revascularizations in the aspirin arm. The strokes and bleeding, I believe, as there's more objectivity to those sort of endpoints. But readmissions attributable to ACS and target vesicle revascularizations are too subjective for me to really believe, especially if this trial was open label in nature. There was also a small randomized post-CABET trial based out of China that looked at whether DAPT therapy with aspirin plus ticagrelor was any different from each of the individual drugs for graft patency. This trial concluded that dual antiplatelet therapy did do better than each of the two monotherapies individually. Although this was a relatively small study, this gives me some confidence that even for CABG patients that there may not be a significant difference in graft patency between aspirin and ticagrelor, possible associated outcomes. In another systematic review and meta-analysis published in 2019, they compared clopidogrel versus aspirin only, which was the question that I would like answered, as I don't envision myself trying to use ticagrelor monotherapy after diving into this topic. Their analysis only included 3 trials. It seemed like it was a well-intended systematic review and meta-analysis, but they were only able to obtain data for a total of less than 5,500 patients. Let's not forget that a similar meta-analysis to PANTHER was actually published last year that included 2 additional stroke or high-risk TIA trials, Socrates and Chance, which weren't really true coronary artery disease patients, and also included the huge close to 16,000 patient global leaders trial instead of GLASSY. But due to concerns of possible lingering effects of DAPT therapy before switching to monotherapy for some of these trials, there was doubt about the validity of the data and how they were derived, and I suspect that might be the reason for why they had to conduct PANTHER. Last, I'd like to direct your attention to this editorial published by Carlin and Eichelboom, both of whom have received financial support from AstraZeneca and various other companies. They make a pretty strong case to use P2Y12 inhibitors over ASA, and they specifically quote both Agrawal's analysis and PANTHER. And I do have concerns about how they address this. Let me know if you're in the situation where you're having to make a decision on whether to continue on aspirin for yourself or a patient you're looking after, or switch to something else like a P2Y12 inhibitor, so we can all learn from each other. So in summary, according to this recent PANTHER meta-analysis, as well as diving into the individual trials and some peripheral literature comparing P2Y12 inhibitor monotherapy with aspirin monotherapy for secondary prevention, it's still questionable whether P2Y12 inhibitors in properly conducted randomized blinded trials actually can outperform aspirin for secondary prevention. It seems that clopidogrel could possibly do that, especially if your patients are not on otherwise good medical therapy with high potency statins, etc. And ticagrelor monotherapy could possibly lead to more events like the ones that they found in TICAP. There is a possible advantage of using P2Y12 inhibitors in favor of aspirin for any GI bleeding, as aspirin is associated with direct mucosal injury along the GI tract, which is a known fact, and I've seen that before. As some of you know, I do have concerns over ticagrelor's safety profile, not only demonstrated by global leaders, Classy, TICAB, and that AstraZeneca just seems to try to conceal it by running these open label trials or terminating studies early. Ticagrelor would not exactly be my P2Y12 inhibitor of choice if I were to switch someone over from aspirin for several reasons as well. It's twice a day, people can get short of breath, it's more expensive. So for patients who are at high risk for GI bleeding, rather than putting them on a PPI for GI protection if they're already on an aspirin, or if you have concerns of either ischemic or hemorrhagic strokes in patients with established coronary disease, I think it might actually be worthwhile to start switching patients over to clopidogrel instead. But if you absolutely don't believe that clopidogrel carries any significant benefit in thrombotic outcomes over aspirin, at the very least, you can somewhat be confident that patients will probably not die if you switch them from aspirin to clopidogrel if you're concerned about something like GI bleeding. Thank you all for watching, and we'll see you in the next one. Say no to drugs.